As Mira said, I am at heart really an anatomic pathologist, but I recently discovered a love for molecular pathology and how it relates to anatomic pathology. So today I'm going to share some of the exciting stuff that we're doing here in our clinical molecular lab. So the patient is a 55-year-old female, and she presented with abnormal uterine bleeding at an outside hospital. At the outside hospital, on the biopsy, the tumor was called just a poorly differentiated carcinoma, and she was referred here to MSK for a total hysterectomy, bilateral salpingo-oophorectomy. So this is a schematic. This is a photomicrograph of the tumor. You can see down here we have normal endometrium, and then you can see here we have a big polypoid lesion in the endometrial cavity that looks rather solid from low power. And if you go into higher power, you notice a couple of things here. We have solid architecture. We have very monomorphic nuclei with prominent nucleoli and some clearing of the cytoplasm. So from a histologic point of view, our differential diagnosis was a solid endometrioid carcinoma with cytoplasmic clearing or a solid clear cell carcinoma. You'll notice here that there are a lot of lymphoplasmacytic infiltrate here as well, which is something to keep in mind. And so after some immunostains, HNF1 beta, NAPSIN-A, and ER, we diagnosed this as an endometrial clear cell carcinoma. For those of you who don't know, NAPSIN-A can also be positive in clear cell carcinomas of the GYN tract, as well as rarely can be positive in endometrioid carcinomas of the GYN tract as well. So because of her tumor histology and the fact that it was involving the lower uterine segment, these are two things that are sort of dead ringers for when we think about Lynch syndrome. So we did the mismatch repair proteins, and actually MSH6 was lost. The other proteins, MSH2, MLH1, and PMS2, were all retained. So because of this loss of MSH6, she was referred to clinical genetics. So a pedigree was constructed in clinical genetics, and she had no family history of cancer. That's okay, because sometimes in endometrial cancer and Lynch syndrome patients, they really don't have a history. So the patient underwent germline genetic testing for all of the genes that could potentially result in loss of MSH6 by IHC, and after sequencing MSH2, MSH6, and EpCAM basically silences MSH2. These were all negative, so there was no germline mutation found. And this is actually the note out of her clinical genetics consultation, basically saying that although they did not find a deleterious mutation, the fact that her IHC was lost, and she also had microsatellite instability testing, which was microsatellite high, as well as the fact that her tumor was in her lower uterine segment, they were still very highly suspicious that she probably still had Lynch syndrome, just possibly a mutation in a gene, in a cold gene that we're not able to detect by sequencing. So this patient, even though she doesn't have a confirmed diagnosis of Lynch syndrome, she still has to be followed like she has Lynch syndrome. So she has to get all the yearly screening. Her family members have to get all the yearly screening. So this is not a benign diagnosis for this patient. It's going to be a long haul for her getting screened, as well as her family members getting screened. So a lot of anxiety, lots of resources being used to screen her, as well as her family members. So just to remind ourselves how DNA mismatch repair abnormalities occur in endometrial cancer, about 20 to 25% of all endometrial cancers show microsatellite instability or DNA mismatch repair defects, but actually most of those are due to somatic abnormalities. And in the past, we thought the only somatic abnormality that could happen in this setting was MLH1 promoter methylation. We didn't really think that there were any other somatic mechanisms besides the MLH1 promoter methylation. But now I have down here somatic mutation. So we found out some new information I'm just going to talk about in a couple of minutes. So as I said, most of these tumors are actually sporadic, tumors that have mismatch repair defects, and only a very small percentage of these cases, and probably about 3% of all endometrial cancers are due to Lynch syndrome. So only a very small subset of these patients actually have Lynch syndrome. So this is a schematic of the current algorithm that we use. This is applicable for endometrial cancer and colorectal cancer. There are a couple differences between endometrial and colorectal cancer in the screening process. So basically, if the patient has all the proteins retained, she's pretty much done, unless she has some sort of clinical history that's suspicious, because I'll tell you the mismatch repair proteins are only 90% sensitive. So we are already off the bat missing about 10% of patients. So if there's a clinical suspicion that this patient might have Lynch syndrome, they do get sent to genetics. Now, if the patient has a protein loss of MLH1 and PMS2, then we automatically send for promoter methylation, because as I said, that's the most common cause of the somatic abnormalities. And if there is MLH1 promoter methylation, the patient is done, no more screening. The only difference between colorectal and endometrial cancer is that endometrial cancers don't have the BRAF mutations, so that doesn't factor into our clinical screening algorithm. So if we have methylation absent, then the patient gets sent to genetics. And if you have MSH2, MSH6, or PMS2 protein loss, they also get sent to genetics. So when I was a GYN fellow, one of our GYN geneticists used to always say, if you have loss of MSH2 and MSH6, that's virtually diagnostic of Lynch syndrome. So we thought that for several years, and we were labeling all these patients, MSH2 and 6 patients, as having Lynch syndrome, when many of them actually probably do not. So when they get tested, if they have a mutation identified, they are diagnosed with Lynch syndrome. If no mutation is identified, they're pretty much still screened and treated as they have Lynch syndrome. So these patients are referred to as having Lynch-like syndrome. We think that they probably do have Lynch syndrome. That's the clinical suspicion. And they are screened and followed as if they have Lynch syndrome. So again, lots of anxiety provoking for the patient, lots of resources spent on screening all of these patients. So as it turns out, we started seeing this in our own institution. A lot of these patients that have especially MSH2 and 6 loss, they weren't finding the germline mutations. And in fact, up to 65% of patients that have abnormal screening results, actually you can't detect a germline mutation. So it's a real problem. Do these patients have Lynch syndrome or don't they? So a couple of groups looked at these and they thought, oh, let's do some somatic testing. Let's see if there's mutations in any of these genes on the somatic level. So as you know, Lynch syndrome is an autosomal dominant syndrome, so you need 2 hits in any gene. You have a germline mutation, and classically, the second hit is a deletion. But what about the possibility of having 2 hits as somatic events? So this group looked at this, and actually, lo and behold, they found that a lot of these cases actually had somatic mutations, and a lot of them had 2 hits. Either a pathogenic mutation and then LOH, or just 2 somatic mutations in the tumor. So this is starting to make sense. A lot of these patients, maybe they just have the somatic mutations and they don't have Lynch syndrome. So coming back to our patient, this patient's tumor underwent sequencing by our clinical test called IMPACT. And just to let you know, this is a next generation sequencing test. And here we sequence both the patient's normal tissue as well as the tumor. And our panel has about 410 genes. Actually, this is actually out of date. We're now up to 468 genes in our panel. And the reason that we do the normal tissue is so that we can rule out any germline events, so that we know that the mutations that come up are somatic. So the germline mutations get automatically filtered out. Nobody sees them. It gets filtered out by a computer program. And so that we know that when we get our results back, those are all somatic mutations that we're looking at. And this is just a list of the 410 genes, again, now 468, I believe. And so the great thing about next generation sequencing is you can test all of these separate genes in one single test. It is sort of laborious because there's a lot of bioinformatics that go into it, and you need a very good bioinformatics team if you're going to do this on a lot of cases. But that's one of the great advantages. You don't have to do single gene testing or sequencing on each one of these. Obviously, you don't need to know the gene status for all of these. This is a little bit overkill. But we like to do things big here at MSK, so we have a humongous gene panel. So coming back to our patient, her results, she had 565 mutations in her tumor. So if you don't do molecular diagnostics routinely, that's a lot of mutations. Your typical tumor has anywhere between 5 and 10 mutations, approximately. So this has a 565, which is a lot. And 2 of those mutations were actually somatic. Well, one of them was a nonsense mutation, so a deleterious mutation in MSH6. And then we detected loss of heterozygosity in MSH6. So we're thinking that, oh, this could be why the patient had the MSH6 protein loss. But there was another interesting finding. There was a mutation as well in POLE. which is DNA polymerase epsilon, and it was one of these hot spots. So it's, it's a common mutation. But what exactly is POLE? So just a little bit of background on what POLE and DNA mismatch repair proteins do for DNA replication. So just to make a long story short, they're very important in the fidelity of DNA replication. So if you have loss of any of the mismatch repair genes, what they do is they correct mistakes that happen routinely in DNA replication. You always have a certain amount of mutations in normal DNA replication. So you have two things that come back and help repair those, and that's the mismatch repair complex as well as POLE. So if you lose one of these, you're going to have a lot of mutations in the tumor, right? Because you're making more mistakes than you normally would. And as it turns out, there's two basically scales of the hypermutability that we see in these tumors. If you have mismatch repair deficiency, we call these hypermutated tumors, and the mutation rate is about 10 to 50 times more than your microsatellite stable tumor. And then these POLE tumors, which appears to be even more important in fidelity because you have even more mutations, and we call these ultramutated tumors. So this is the endometrial TCGA. I know this is a little bit of a scary slide, but I'm going to simplify it for you. So basically what they did in this TCGA, they looked at both endometrioid and serous cancers, and instead of your traditional two types, according to Bachman, if you remember him, he classified endometrial cancer into type 1s and types 2, low grade and high grade. Actually, there's probably at least 4 molecular subtypes of endometrial cancer. So over here you have what's called the serous-like, that's your typical serous cancer. Over here you have your copy number low, that's your typical low-grade 501 endometrioid carcinoma. You guys are all familiar with those types. But there's actual 2 types that I just want to mention briefly. The MSI high category, so these are tumors that have DNA mismatch repair abnormalities and microsatellite instability, also hypermutated. And then this POLE group. So probably a lot of you may not have heard about POLE. Basically, they occur in a subset of endometrial cancers, and they have lots and lots of mutations, just like I said. The interesting thing about the POLE group, about the TCGA, is that it actually worked really well for prognostication for endometrial cancers, better than our histologic diagnoses. As you can see here, progression-free survival based on these molecular subgroups was statistically significant. So as I said, POLE, they're ultramutated tumors, and actually some of them also show microsatellite instability. That's because what we think is happening is because we don't have POLE anymore, so you're making lots and lots of mistakes. So eventually you're probably going to hit the mismatch repair genes. So some of them also have microsatellite instability. So our patient had POLE and microsatellite instability. And it has to be in a specific location in the gene POLE. It's called the exonuclease domain. And approximately about 5 to 7% of endometrial cancers have these mutations. And the very interesting thing about it is even when they're at advanced stage, they all have excellent prognoses. There's only been one reported case of a recurrence in the literature that I know of so far, which is very interesting because we traditionally think that once your endometrial cancer is outside of the uterus, it's uncurable. But we have lots and lots of years on follow-up of a lot of these patients that are actually doing very well. And we think that maybe they also get the secondary mutations in the DNA mismatch repair genes, which accounts for the protein loss. And also, another very interesting thing about these POLE tumors is they are frequently classified as high grade. This is a picture from a paper that was written by Yasser Hussain, one of our distinguished alumni and former attendings. So basically, they looked at all the POLE tumors that were sequenced in the TCGA. And you can see up here on the left, a lot of them are low-grade endometrioid tumors, histologically appearing at least, but a lot of them look very high-grade and look almost serous-like. This one down here, for example, has the tufting and budding and the high nuclear grade you would typically see in a serous cancer. Also here, you have some solid architecture, but you have some very ugly, bizarre nuclei. Same thing down here, very serous appearing, these really prominent nucleoli. So these are things we would call high-grade endometrial cancer. But conversely, they have extremely good prognoses. So getting back to the Lynch-like problem, as we're talking about POLE, another group from the Netherlands looked at this problem as well. They looked at 32 patients. The patients both had colorectal and endometrial carcinoma. And they basically looked at the patients where we could not find a germline mutation. And so basically what they found was the same thing as the other group. A lot of them had 2 hits, somatic hits. But as you can see, 5 out of the 22 also had somatic mutations in POLE. So we think that this is probably what's happening, that these tumors get secondary mutations in the mismatch repair genes, and so they have loss of protein, and they're flagged as being potential risks of having Lynch syndrome, but actually they probably don't. So there's a lot of things as in this specific case, we were able to figure out by what was going on by somatic sequencing. So this is, one of the tools that we can use to figure out cases like these. It's very convenient to be able to look at lots and lots of genes simultaneously. So this actually probably will in the future become standard of care for these patients, doing somatic mutation testing. So we can define if there's somatic mutations in any of the mismatch repair genes as well as POLE. And it's very useful to be used in combination of germline testing because we can do next generation sequencing of the germline as well, correlate those two, and then actually you're saving a lot of resources because you're only doing 2 tests, as opposed to the multiple single gene tests you may have to do in the setting of classical genetics. The one thing we don't do right now is detect MLH1 promoter methylation, so that's a separate test still. So as I mentioned, we do have an initiative here where we're doing impact germline sequencing. So again, it's very, very advantageous that we can look at lots and lots of genes at the same time. Much more cost effective and efficient than doing single gene tests. And having a negative germline result with the combination of having the somatic sequencing can really help determine what's going on with these patients so they don't have to live their life screening themselves for tumors that they will probably never get. So this is just a picture of the genes that we have on MSKCC germline impact, and we're sequencing a lot of patients right now. These are mostly just all cancer-related genes, because obviously that's really all we care about here. So it's a great test, and we're learning lots of great things about it. There is a lot that goes along with it, though, because you need a really, really good bioinformatics team. You need curators to figure out, are these deleterious mutations that we're finding or not? So it takes a lot more effort and time than looking at the somatic mutations. And if you're looking at mutations in the 80s plus genes, you're going to get a lot of variants with unknown significance. Those in itself can cause a lot of anxiety. So, there are lots of advantages, but there also are some disadvantages because you're going to get a lot of uncertain results. Because one of the issues is that there were a couple of companies that did most of the germline sequencing, and they have their own databases. So to really know if something is deleterious or not in many situations, you need to see it again and again. And these companies actually are not sharing their data. So we want to do this in-house, but of course we have to start from scratch with our databases. So it's a big effort. And this is just a typical output of some germline mutations in patients. You can rule some of these out very easily, but it's a much longer and laborious process, each single mutation that you're looking at. So typically, we can also use next generation sequencing to determine microsatellite instability. This is a schematic of traditional microsatellite instability that we do by PCR. And so when we're looking at microsatellites, we're looking at about traditionally 5 loci. So we're only looking at 5 markers by PCR. But the great thing about next generation sequencing is we're sequencing a lot of genes, so we can look at a lot more loci. So there have been some tests out there, some commercial tests, in which the sensitivity is actually really, really good, equal to PCR. And then we've developed actually our own adapted a test here where now we are reporting the MSI status for every endometrial and colorectal cancer that we sequence. And this is just a schematic of our data here when we validated the test. Basically over here on this axis, you have a score. And everything above 10, we correlated with microsatellite instability. This axis over here is the number of somatic mutations here. So if you look at all the mismatch repair deficient cases, lots of mutations, hypermutated cases, and they showed most of them, showed microsatellite instability because they have a score of higher than 10. Then out here you have some POLE mutants, have lots and lots of mutations, but don't have microsatellite instability. So again, most POLE cases, tumors, don't have microsatellite instability. It's only it's about 1/5 of them that actually have microsatellite instability as well. So why else is this important? Why else are we going to start sequencing on endometrial cancers? And why are we going to classify these? Not only because it informs prognosis much better than the traditional histologic classification, but it also has implications for therapy. We know that in colorectal cancer, determining microsatellite instability testing has been important for therapy for quite a while, but is actually only getting started now in endometrial cancer. And one of the techniques to target these tumors is due to the high mutational burden that they have. And so when you have a lot of mutations, you have a lot of neoantigens, basically, and they get presented on the cell surface. And so your lymphocytic response is elevated because of all these neoantigens. And if you look here, this is an example of microsatellite high tumor. You can see all the lymphocytic response here, which is typical for microsatellite high tumor. So this is because of all the neoantigens that it has. So basically, when you have this lymphocytic response, you get these inhibitors that dampen the lymphocytic response. So the goal is to inhibit the dampening of this lymphocytic response. So these are the PD or the PD-1 inhibitors that are out there right now. So basically what you're trying to do is inhibit these immune checkpoint blockade so that we want to increase the immune system. So that's what's happening right now. And in fact, imminently this clinical trial that I'm involved is going to be starting. It's a PD-L1 inhibitor, nivolumab, and patients with persistent or recurrent endometrial cancer will get immunotherapy if they have microsatellite instability, mismatch repair deficiency, or if they're hypermutated. So it's here, it's not only just for Lynch syndrome that we need to be doing the mismatch repair proteins, but it's going to affect the patient's therapy as well. So back to our patient, as expected, she's 7 years, no evidence of disease, and she does not have any other additional cancers. Her family members don't have any additional cancers. So just to summarize, we think that this group of patients with Lynch-like syndrome, probably a high percentage of them are due to somatic mutations in the mismatch repair genes, and they can have mutations in POLE as well, which most likely cause the secondary somatic mutations in the mismatch repair genes. And next-generation sequencing is going to be a useful tool in the future to be able to study these patients and hopefully save them from all the screening and the anxiety that goes with having a diagnosis of Lynch syndrome. And as I said, detecting mismatch repair deficiency is important in endometrial cancer now, not just for Lynch syndrome, but also for prognosis and therapy. Questions?